rates, costs, and side effects. Those are the components of our program. We have training for general practitioners, radiologists, technicians, and nurses. The women enrollment and follow-up is based on auxiliary nurses, they're not professional nurses, and GPs. This is the basic personnel we're using for the screening program in our country. And it is hospital-based recruitment. It means that screening is offered systematically to all women attending the health centers on their own, regardless the motivation for the consultation. And after that, we screen them with CBE and mammography, and then we follow up according to the screening results. We have some educational activities through informative talks, guidelines for patients, and printed material. And this is a very important component for our country, our program. We do quality control of mammography on machines. We review the machines before starting the screening and review them every 6 months to follow the way they're improving the machines, the mammography machines. We do quality control on the mammography films and on the mammography reading. And something very important is that you should think about clinical breast examination as a health technology. It means they could have false positive and false negative results. So we implemented a strategy for quality control of clinical breast examination within the program. And we have some indicator for program monitoring. We're following up all the time the progress of the program. This is a brief description of the GP's training program. It is a one-day course on breast cancer epidemiology, breast cancer screening, both with mammography and CBE, diagnosis of breast cancer, and they have some practice of CVE on phantoms. And additionally, after this one-day course, the breast surgeons go to the clinical settings, and they have some supervision of clinical practice on CVE on site. Some of the resources qualify. We get, until now, 359 general practitioners qualified for 44 nurses, 13 radiologists, and 35 technicians. This is the centers participating in the study. This is a mistake. The average GP per health center is about 12. And something very important for us is that the high rotation of general practitioners is quite a challenge for establishing a regular screening program. After the initial training, we have to train additional 100 GPs to keep the personnel properly trained for the screening activities. We conducted a baseline survey on CBE and mammography coverage in order to evaluate the impact of our intervention. We have two kinds of data here. The one is lifetime prevalence of mammography and lifetime prevalence on CBE. Lifetime means mammograph history of mammography or CBE anytime in the woman's lifetime and for any purposes. No difference between diagnosis or screening. And the coverage of the screening prevalence for mammography or CBE implies for mammography the history of mammography during the 2 previous years to the survey and only for screening purposes. And the CBE screening prevalence means the history of CBE during the previous year to the survey and only for screening purposes. I will refer only to the screening prevalence. You may see that there is a huge difference between the history of mammography and the history of CBE, which is higher for mammography among the HMO population, the health insurance plan for workers and the relative. And something unexpected was the high rate or the high prevalence of mammography within the previous 2 years. We think this is a biased sample. It's a biased sample because we invited all the HMOs present in Bogota to participate in the study, but only 4 of them were willing to participate, and probably the 4 who are participating in the study are maybe those that were already doing something for breast cancer screening in the city. And it represents a challenge for the intervention because we're not sure if we're going to impact very much the coverage of mammography after the intervention. But this is a different situation for the people, for the uninsured women and the subsidized women in the city. Something interesting is that you see here the uninsured women has better coverage for mammography and CVE than the subsidized women. And that's interesting because we think that maybe the local authority, the local health authority is doing better for screening than the health insurance companies for the subsidized people regarding the fact that they don't have any any mandatory activity on breast cancer screening in the city. Some additional preliminary results about the situation of the study will have included 24 randomized clusters. We currently have about 12,000 women included in our pilot, and this is an interim analysis based on only 6,000 women included in the study. You may see that within the control group, only 27% of the women have received a mammography order. In the intervention group, 100% of the women have received a mammography order. And among those women who've received a mammography order, in the control group, 72% have undergone mammography, and in the intervention arm, 95% underwent the mammography. The clinical breast examination was done only in 7% of the women in the control arm and in the 100% of women in the intervention arm. And something was mentioned in the previous talk was about the side effects of screening. So we know we have to look for the information on the intervention of the breast, like biopsies or other clinical procedures on the breast, but we only, until now, we only have the information about ultrasound. And you see here that the proportion of ultrasounds performed in the control arm for all women is 1.1%, and in the control arm is 5.5%. In spite of this is higher than in the control group. It means we think that it doesn't represent something that is not feasible or sustainable for our screening program. If we review the data, not regarding to all women in the control arm, but only to the women with a mammography order, there is no difference between the control and intervention arm. It is 5.9% and 5.8% in each group, respectively. And some outcomes, the main outcomes we reviewed in our pilot are the cancer cases we have detected. And you see here that we have 6 cancer cases detected in the no-intervention group and 14 cancer detected in the opportunistic screening group. It means that we have doubled the rate we were expecting before starting the pilot. With a higher rate, it's obvious. If you look for it, you will find more. And the stage B or more, which is the local advanced cancer, show us that 0.3% of the cases have been found in a local advanced stage for the control group, and only 0.10% of the cases have been found in a local advanced stage for the intervention group. We're expecting, because we haven't finished the follow-up, the 1-year follow-up I mentioned before, so we're expecting to have a couple of additional cases in the control group, and maybe it will increase the difference between both branches in the study. And this is the distribution for early stages. You see here that stages inside of stage 1 the proportion of these cases is higher in the opportunistic screening branch than in the control group. And we have found only one ductal carcinoma in situ, which is one of the worrisome in a breast cancer screening strategy regarding the chance of overdiagnosis of breast cancer. So with this data, we think that we are sure that we need the final results, but they're showing us that implementing this kind of opportunistic screening is feasible for us, and maybe we will be successful downstaging the disease in our country with this strategy. I want to acknowledge our research team, and the participation institutions. Thank you very much for your attention.